Hi, everybody, and welcome to this TCOYD Live. I am one of your hosts, Dr. Jeremy Pettus, joined, as always, by my good buddy,
Dr. Steve Edelman.
So we are here in our TCOYD studio, which is awesome. We just had our holiday party here last week, which was amazing.
People are still talking about it.
So we're really excited to be doing this TCOYD Live. Obviously, here we are in December, holiday time, and just so much to talk about, with the holidays. The holidays can be this kind of dual thing, right, for people with diabetes. There's a lot of fun and merriment and people getting together. That can also be stressful. There's lots of foods and you're probably overeating, over drinking like we all do. So it's how do you manage all this, like this time of year?
Yeah, you might have some annoying relatives and friends who look at everything you're putting in your mouth. And so we'll talk about that a little bit more, but the bottom line is you got to enjoy the holidays.
So because the holidays are there's so much going on, we've actually made a couple songs specifically about the holidays. So we wanted to kick things off, get us kind of in the spirit of holidays and this theme by playing our more recent holiday song called, get this, the holiday song. So Eric, go ahead and roll it for everybody.
So many holidays this time of year. The cookies, pies, and dinners all put the fear of God in me. Why can't I just stay home? Let me eat alone without Grandpa Stanley's advice. Last month my A1C was 6.5. I smelled some pumpkin pie and now it's 9.9. Sometimes it feels like I'm the only one and it's just no fun, but I'm doing all that I can. My brother made a pecan pie, but if it's sugar-free I am going to cry. So light the menorah, trim the tree. Together we're TCOYD. My doctor says I need to exercise, but when I do I might get low or get high. No, I'm not talking about the thing you smoke. That was just a joke, not the greatest joke, but okay. My family's here and now it's dinner time. My CGM's been going up all day night. It's like I'm on a roller coaster ride, but I swear I'm trying just to live with this every day. But Santa Claus has been kind to me. He brought me something called TCOYD. So whether you've got type 1 or 2, TCOYD is there for you. Santa Claus has been kind to me. He brought me something called TCOYD. So whether you've got type 1 or 2, don't give up no matter what you do. Cause I'm like you and you're like me. Together we're TCOYD.
All right, so we're back. So we were listening along with you guys. We've had so much fun making these songs. It reminds me, again, for our holiday party, we actually performed live, literally where we're standing, a couple songs. So if you want to see those videos, please go to our website, tcoyd.org. You can click on Watch and click on Original Songs. We have probably 10 of them now with full-length music videos. Also there, of course, check out our video vault. All kinds of topics on literally everything type 1 and type 2, exercise, medications, whatever you want. It's all there free to help you manage your diabetes. Also, you can get to our podcast. So really so much good information for you and your diabetes there.
And these songs, we have over 10, and to qualify for Spotify and Apple Music, it has to be a unique new song, and we have over 10. And we should also mention, you don't see Eric, our ultimate producer, director, singer, songwriter, musician, but he's the mastermind behind all that. He tells Jeremy and occasionally me what to do on these songs, and we are indebted to him.
So, all right, so getting into our theme, what everybody wants for the holidays, Christmas, whatever you celebrate, what would be kind of waiting there for you when you woke up on Christmas or whatever?
I want a cure for diabetes.
Exactly. So that's the elephant in the room, right? What do we really want? We don't freaking want diabetes, like end of story. However, if you're listening, there's a good chance you have diabetes or somebody you love. So what are some things that can make life, easier, whether you have type 1 or type 2? So we're going to go kind of, back and forth in that area. So starting with type 1 diabetes, yes, we want a cure, but, I have here a safe, effectable, affordable way to obtain new beta cells. So I celebrate Christmas. So gosh, wouldn't it be nice under the tree, a little wrapped little bowl of beta cells that I could give myself back?
It's got to be a small bowl. You don't need that many.
You don't need that
I mean,
many.
they're small. They're very small.
It could be a tiny little engagement box or something like that.
Yeah.
But there is, kind of jokes aside, a lot of good things happening in this area. So we've talked a lot, on different programs about new stem cells that get this. With stem cells, we now have the ability to make as many beta cells as we need to treat everybody in the world with diabetes. And that is such a big breakthrough because we used to rely on, people that are organ donors that were in a car accident or whatever and would donate their pancreas. And so there was a real supply issue.
Yep.
And we've basically overcome that now with the ability to replicate these cells to infinity. And now we're just figuring out the best way to give them back to people with type 1 and type 2. And probably leading the way is a company called Vertex. You might have heard about it. They were in the New York Times, different articles about they've started their clinical trials with taking these islets, and you're right, he's not kidding. You just need a small amount, a little thimbleful,
Yep.
infusing them into one of the veins so that they actually go into your liver of all places. And once there, they can sense glucose, they can secrete insulin as an effective cure. The downside is that you need immunosuppressive medications because these are not your beta cells. Your immune system would recognize them as foreign and try to destroy them. So you need immunosuppression, but that trade-off, could be acceptable depending on where you are with your type 1.
Well, I should mention that there's a new technology that you may have seen in the news lately called CRISPR. Mm-hmm. It's not really meant to make your lettuce stiffer.
That's a good joke.
But CRISPR is a technology that modifies what you're trying to keep away from the immune system.
Well, you basically modify these cells, and so the hope is
Yeah.
that you can modify them to one day be kind of invisible to the immune system, so you wouldn't need immunosuppression. So, please don't just bombard us with emails and phone calls because, this isn't available yet. But you can go, look at Vertex's website,
Yeah.
find out if they're doing a clinical trial in your area.
Yep.
If you might want to sign up.
Yeah, it's tremendous progress in this area. What else?
Well, so I've been talking about, and Steve's, hearing me talk about, there's this company called KRIA, K-R-I-Y-A. And it's a little bit complicated what they've developed, but it's really, really cool. That essentially they're developing a therapy that they have done this now in rats, dogs, and now monkeys, where they're injecting a virus that can encode a gene for insulin into people's muscles. So basically, long story short, it can take these animals' muscles, and ideally humans eventually, and encode the insulin gene in the muscles to make your muscles secrete insulin. So instead of saying, oh, we need beta cells, those are the only things that can make insulin, it's, hey, we can kind of modify other tissues to become beta cells. And in that way, if you did that, you actually might not need immunosuppression because it's just kind of using your own cells.
Yeah, when Jeremy says virus, it's not like the COVID virus.
Yeah, it's
Not
a way
dangerous.
of just getting a gene into your muscles. And it sounds complicated, and you're like, yeah, I don't want the flu.
Can
or
they put it in
anything
my
like that.
bicep area?
Not maybe yours, because it's probably too big and you'd have too much insulin, so it's problematic. But
It's amazing technology.
But isn't that wild? I mean, so not under the tree this year, but honestly, that kind of thing might be just 2 years away, something like that. We always joke about, type 1 was going to be cured in 10 to 15 years. They said that when Steve was diagnosed in 1918, and when I was diagnosed in 1994. It's always been 10 to 15 years, but we're getting there.
That's not right.
All right, so under the tree, beta cells would be great. Let's switch to type 2s.
Okay.
What's the one for them?
Okay, my wish for the type 2s out there to go under their tree and have full access to GLP-1 receptor agonists. What am I talking about? Victoza, Ozempic, Trulicity, Mounjaro. And the
Everybody's heard of these. Everybody in Hollywood, right, is on Ozempic and losing weight. Everybody knows about these medications.
And they shouldn't feel, no one that's taking these drugs to improve their weight should feel guilty or have any shame over it. Because these drugs, and what I'm about to say is that, when the FDA approves drugs, every single one of these were approved for one thing, to improve the blood sugars in people with type 2 diabetes, the A1C. So then when they did more and more studies, they realized that these drugs do way more than just control the diabetes. They reduce heart attacks and strokes. They can actually been shown to reduce congestive heart failure. They've been shown to reduce the progression of diabetic kidney disease, and they can help with weight. And when you reduce weight, you reduce insulin resistance, fatty liver, GERD, like heartburn,
Sleep apnea.
musculoskeletal issues, to the point of weight loss, like 25, 30%, where it negates the need for bariatric surgery, which doesn't have any other secondary benefits. So,
And it is kind of rare, we were talking about this again earlier, that usually when medications come out, 3 or 4 years later, something negative, it's been associated with this, and it kind of dampens excitement. This class of medication has really been a breakthrough. And every couple of years, it's good for your heart, it's good for your kidneys, you're losing weight. There's actually some data now showing it's good for addiction, helping people curb, with alcohol and substance abuse. I mean, it's like, give me a break.
Hasn't helped you.
Yeah. Thanks.
But you know what? It is, I'm very serious when I say that when you look at the treatment algorithm that they give doctors to treat people with type 2, usually, of course, there's diet and exercise. And I don't want to underemphasize that. That's so important. And then they say typically metformin. But nowadays, they ask doctors to ask themselves about the particular patient. Is there heart disease? Is there kidney disease? And if there is, they suggest going to the GLP-1s first, along with SGLT2 inhibitors like Jardiance and Farxiga, depending on which abnormality you have. So it's not just rote metformin first, this other drug second, third. You have to look at this, what you have in terms of medical conditions. That's going to dictate what medications you're going to be on. We also have good lectures on that in our video vault for type 2. And I should also say that we're going to do a podcast that's going to be heard on Christmas Day on this exact topic.
Yeah.
So if you're not in front of your television and your mother-in-law is driving you nuts, you can just put in your ear pod and pretend like you're listening to music and listen to us.
Well, I would say these medications, this sounds weird, but this is a real benefit of having type 2 diabetes, that you can get access to these medications, that you can qualify, you should ask your provider for you. And I can't tell you, seriously, the number of friends, family members, et cetera, that I've had call me, to try to get these medications. It's like, sorry, you don't have diabetes, you don't qualify for them. Take advantage of the fact that these medications are actually available for you, and maybe they'll be under the tree for you.
Yeah, and I think, there is access problems depending on where you live, what your socioeconomic status is, ethnic groups. They've studied that certain people have easier times getting them than others, even when it's available.
Even if your insurance covers it now, they can't make enough of this stuff.
Yeah.
The patients will say the pharmacy's out. Keep calling. That really helps. If you say like, they'll just call me when it's available, nope, you're going to be at the bottom of the list. Keep calling, letting them know that you're interested, that you want to get this medication, if the issue is that they're out of it, because they can't make enough of this stuff.
It's like buying tickets to the Stones. You have to sleep overnight and right at the Ticketmaster window when that shipment comes in. But I should also tell you that companies like Lilly that make Mounjaro and Novo that makes Ozempic and Victoza, they are building plants around the world, production plants. Now, the last thing I want to say is this, and I'm sure it's true with you. A lot of my patients with type 2, some of you listeners or viewers, they say, do I have to take this medication the rest of my life? The answer is yes, because you don't want to stop this medication. You don't want to stop a medication that protects your heart and your kidneys, controls your diabetes, and helps keep your weight off. And they've shown that when people stop the medication, these issues come right back. And remember, GLP-1 is a natural hormone. And so you're not taking some synthesized drug from Botswana. And I don't know why I said that, but this is a natural hormone that you're replacing. It's called incretins. So it's natural, just like insulin.
Well, now, I kind of want to switch to something for type 1. And guess what?
Hey, I want to talk about type 2s.
It's the same wish. So we just talked about all these benefits of this class of medications, but they're not approved for people with type 1. It's difficult for type 1s to get Ozempic and Mounjaro, all these things that you literally can't turn on the news without hearing about. So here's the thing. These drugs absolutely work for people with type 1 diabetes. We know that. They've been studied, help with blood sugars, weight, and we assume they'll have the same benefits with heart and kidney and things like that. The reason they, aren't approved is they haven't been officially studied in type 1, which means insurance companies won't pay for it.
Or they use that excuse
Yes.
not to pay for it.
So I can prescribe these medicines all day long to every single type 1 I see. They just likely won't be covered, and they're just too expensive for the vast, vast majority of people to pay out of pocket.
Yep.
Now, there are some workarounds. So a lot of these medications now are approved specifically for obesity. So if you have type 1 diabetes and you have issues with your weight, specifically if you are obese, and that has a medical definition, you should go online and Google your BMI calculator. And the definition of obese is a BMI anything over 30. If you're overweight, it's between 25 and 30, and then obese is over 30.
And let me just say that they will approve it officially if your BMI is 27 or greater, and you have multiple, what they call cardiovascular morbidity, like high blood pressure, abnormal cholesterol, family history of heart disease. So theoretically, if your BMI is 27, you can get these medications, or you can at least have the justification to get them.
And your provider has to put it in as for weight loss, because if they put it in, or for obesity or weight, if they put it in for type 1 diabetes, it'll get denied.
I want to give it to Jeremy. I got denied right away.
Now, there is some hope specifically in trying to get these drugs approved for type 1 diabetes. So there's a company called Carmot that has developed a GLP-1-like drug like Mounjaro that they're studying specifically in type 1 diabetes. So this medication is in research studies right now, and it's a once-a-day medication. And their thinking was, well, gosh, there's a lot of options for type 2s, and most of them are once a week, so we might not be competitive in that area, but maybe in type 1 we would be competitive because there's nothing else. And this company right now is in clinical trials, like I said. Just last week got bought by a company called Roche, a big diabetes company. Forget this, $3 billion. And that's good for people with diabetes because they're committed to doing this in type 1. So again, probably not under the tree this year, but honestly, maybe 2 years or something like that from now, we would actually have an approved drug for type 1 diabetes. So no more of this insurance games, things like that, because these medicines are so helpful, we got to get type 1s using them.
Maybe you'll stop whining and complaining
that's what you
that
always
type
say.
2s have the greatest drugs. We should mention that the class of drugs called SGLT2 inhibitors that are approved for people with type 2 diabetes, Jardian's Farxiga, approved for diabetes control, but then later discovered that they are very effective about helping people with congestive heart failure. It's actually the most common cardiac abnormality in people with diabetes, not heart attacks, but congestive heart failure, and very, very strong data on protecting the diabetic kidney, preventing the progression of diabetic kidney disease. And once again, the indication on the label, this is sort of like the obesity story, is that it says it's indicated for people with and without type 2 diabetes who have chronic kidney disease. So people who have type 1 are in the category of without type 2, which means that it's available to anybody. So you can get this drug, which has other benefits for people with type 1, but primarily for the kidneys.
All right, so leaving that behind, and by the way, if this is alphabet soup to you, these numbers or these names are being thrown around, please again go to our website. You can click on Watch Video Vault if you have type 1 or type 2 and see these lectures on all these different classes of medications. You can hit pause and see the names and write them down and take that to your provider and ask if these might be for you. Steve, hit us with another one for type 2s.
Okay, so every type 2 should either have or have under their Christmas tree this year a continuous glucose monitoring device. Now, many of you know or may not know, they're only approved for people with type 2 on insulin. But we feel, and we've been talking about for years, we are so far ahead of our time that people with pre-diabetes should have access to continuous glucose monitors, these little devices that measure your blood sugar every 5 minutes throughout the day and night, including people on oral medications only, not on insulin, or if they're on injectables like GLP-1s. Every single person with type 2 diabetes along their whole, what we call natural history, should have access, because not only it'll help adjust medication for those of type 2s on medication, especially insulin, but it's a tremendous behavior modification tool that people see the results of what they eat, how much they eat, how much they exercise, the intensity, and they can actually get super motivated to keep their blood sugars in that desirable range, 70 to 180. And so we've seen that in our practice. Patients somehow buy it on their own, or they're not that expensive these days. We'll talk about that a little bit. But it's amazing how it turns their whole mindset of taking control of their own diabetes. And you don't have to be wearing them 24/7, for example. If you have pre-diabetes, you can wear it for a month and leave it off for a few months. But most of my patients who get it in the early stages, they don't want to take it off because it gives them so much information.
Yeah. And thankfully, we've won this fight in type 1 diabetes, quite a while ago. I wore my first CGM in 2010, but I do remember then my own provider saying, this is too much information, you're not going to need it. Gosh, it's going to just be, bothering you, and you're going to take too much insulin and go low. Man, we know now that these people have better blood sugars, better quality of life, less, low blood sugars. So thankfully, we're using them more and more in people on insulin now. So if you have type 2 diabetes on any kind of insulin, you can get one of these.
Yes.
You should know that.
Even if you're just on basal insulin.
Yeah.
When Jeremy came into the clinic 10 years ago, he came in and he introduced himself. He was on multiple daily injections, and he didn't even know what a CGM was. I lost my shit.
It's a true story. We actually reenacted that whole time when I met Steve, and he ridiculed me.
In a nice way.
No, not really. But it's on the website.
Came from a place of love.
You didn't even know me. But you can watch that again in the video. All right, so continuous glucose monitoring for all. So under the tree, we got beta cells, we got new drugs, we got continuous glucose monitors.
So yes. Add one more thing. You're right. Good summary.
Yeah.
The new CGMs, like the G7 and the Libre 3, come in these little boxes.
Yeah.
Like a soap box. And they're easy to put on, they're easy to use. And then they have the implantable CGM, the Eversense, if you like that form factor. Medtronic has a sensor. So there's choices. And so I feel so strongly about that. So I've covered the GLP-1s, a little bit SGLT2s, and the CGM. How was that for
That's just
recap
a lot
for
of
type
letters.
2s?
Yeah.
You know what? You would have the best year of your life if you type 2s got either one of those that you don't have now.
All right, so a wish list for, particularly for people with type 1 diabetes, is a truly rapid acting insulin. So I think the term that we use for rapid acting insulin now is just the worst term for it ever, because it's anything but rapidly acting. So I don't care if you use Humalog or Novolog or Lumjev or Fies, whatever kind of mealtime insulin you use, it takes 30 minutes for it to start working. It peaks in like 2 hours and it hangs around for 4 or 5 hours. That's very different than what the beta cell does in people without diabetes, where it literally secretes insulin within seconds. It hangs around for a couple minutes. So it's this really sharp tool, this rapid on, rapid off. And we're trying to emulate that with like steering the Titanic of this really kind of lousy
It's
insulin.
easy to oversteer
Yeah.
and it's easy to understeer. But Jeremy should qualify that we have a Afrezza, which is the inhaled powdered insulin, but we want it also in a liquid form. So us type 1s can put it in our pump.
Yeah. So I didn't interrupt you during your.
Well, you forgot to say something important.
You didn't give me time. I'm kidding, but
I'm kidding too.
So yeah, It's really hard. And you wonder why we have highs after eating and we go low. I mean, you look at how slow our insulin is, it's no wonder. But if we had like a truly rapid acting insulin in a liquid form that we could put in a pump, then it's really game over. So the thing that's limiting these hybrid closed loop systems right now, whether you're on a Tandem or Omnipod or iLet or whatever, it's the insulin. The algorithms are really, really good to know how much insulin to give and things like that, but they're limited by how freaking slow this insulin is. So as soon as we can get, something, very rapid acting in a vial, it's going to be a game changer.
Wrap it on, wrap it off. And that's why, I can't tell you how many of my patients, or I've said to myself, I cannot believe how slow this fast-acting injected insulin works.
Totally.
And you know what's interesting?
What's interesting, Steve?
People never discovered this until they got CGM.
Totally.
Now, when they got CGM, they're going, what the heck?
Just you're 300 and you're taking insulin, bolus, nothing happens, and then all of a sudden, boom.
Then the famous rage bolus, and then boom. And then you eat everything in the kitchen sink, which probably relates to...
this next one.
Yeah.
So I'm going to take another one since you were going on and on about your thing.
Well, now, don't forget, so this insulin is, like Jeremy said, primarily for type 1s. A lot of type 2s would enjoy using this. And same with this next topic.
Which is, we're calling mini dose glucagon. So we've had glucagon forever, right? Where we reserve it for kind of really bad low blood sugars. God forbid Steve passed out, had a seizure, something like that. I would give him a glucagon injection to bring his blood sugars up. But now they have glucagon that's kind of stable in a liquid that you can have it around for a long time. So there's an opportunity to make little doses of glucagon. So instead of these emergency situations of, it could be, well, I'm going to exercise, and instead of eating a bunch of carbs to bring my blood sugars high, or I'm going low and I don't want to eat a rack of Oreos and half a pizza and some cold tricks and go to 400. What if I could just take a couple units of glucagon to bring my blood sugar up, save the calories, have it act like a little quicker? Would be fantastic.
Without the rebound.
Yeah, exactly.
So Xeris makes an injectable pen called the Gvoke HypoPen. It's just like Epi. But it is the rescue glucagon dose. You just pull off the cap, you push the spring, and you get it just like that. And the data clearly shows that you don't rebound really high. Now, the other thing I want to say is, Jeremy mentioned tricks. I appreciate that. He knows how much I love tricks. Whenever I eat ravenously, because my blood sugars are low, I get shaky, sweaty, just doesn't taste as good. And you sort of don't even appreciate it that much. And before you know it, you've consumed 500 frickin' calories.
Oh, it's like, if you're lucky, more like 2,000, like depending on how low you are. But God, that's just the worst.
Yeah, so this, but this, in the future, like Jeremy said, they're going to be able to, you'll figure out how much you need for a certain blood sugar and how fast it's dropping, and you inject it, and it works within minutes. So it's going to be so good. You'll have a little pen to use, and maybe even inhaled glucagon. Who knows what they're going to come up with.
So, before I forget, some people are already doing this, but you can please put some questions in whatever you're watching this on, and we'll get to as many of those as we can kind of at the end of this, which we'll be wrapping up soon and get to your questions. So, Steve, a wish for type 2s.
Well, I think this is an important wish, especially for type 2s, is to really get and have under your tree a primary care doctor that truly knows about diabetes, maybe not as much as Jeremy and I, an endocrinologist, but listens to you and addresses your most important issues. And I hear so many complaints about their doctor who says, I'm behind, you get to mention one problem. And primary care doctors, God bless them, they've got to cover lots of diseases because they cover lots of different things. We are pretty narrow. And so I think that's something that I hear so much. People are looking for a good primary care doctor, and that's important for all of us. We get in a car accident, and you want someone that does the standard of care, like the yearly cancer checks, all the different things you need to do to stay healthy, the vaccines, and that's one of the biggest problems. You have a good primary care doctor?
I don't have you're my primary care doctor, so yes. I'm the best primary care doctor in the world.
I'm not a primary care doctor. You don't want to come to me. I don't really know about, a lot of the issues that you have.
Well, then hopefully under the tree for me this year will be a big present that's kind of muffled screams, and I'll unzip it and be some guy there that's just like my new primary care doctor.
Could be a lady.
Or a lady, whoever.
Yeah.
So that's a great one. So, all right, like kind of a big picture one that we want for everybody with diabetes this holiday season is just kind of understanding of how difficult this time of year can be for people with diabetes, for people to try to, keep their helpful comments to themselves. And if you are living with diabetes, as I mentioned in kind of the beginning, a lot of us indulge, over the holidays. And what's the worst thing that you can do is not be realistic about that. I'm not gonna have any pie, or I'm not gonna eat that much, or I'm not gonna drink that much. But guess what? You probably are. So just letting yourself like kind of be okay with that. And I know for these couple days, yeah, I'm gonna eat way more than I usually do, or drink more, or whatever it is. So you can actually enjoy it rather than just constant like doing it and beating yourself up. And just saying, hey, I'm going to get back on track on Friday or January 1st or whatever it is. But the worst thing you can do is just indulge and then give yourself a hard time about it.
And not enjoy it.
And not enjoy it.
So there's so much guilt and shame, and you're gonna have to deal with maybe some of those annoying relatives that care about you and watch everything you eat. So I usually get like a little cardboard stand and I put it around my plate so people can't see what I'm eating, and that gives them a strong message. Don't look at what I eat. But you know what? It's going to be there. You just got to learn how to deal with it. And it's so important that you got to do everything you can to enjoy the moment.
All right, so that's kind of our presentation, I suppose. And we do have some questions here that I'll start just going through. One was asking about this kind of gene therapy I mentioned. It says, how is the insulin rate determined by the gene insertion of the insulin gene? And it's complicated. But basically, they're doing two different genes. There's an insulin gene and another one called glucose kinase that works as kind of an on-off switch for the insulin. When blood sugars are a little bit higher, the insulin's more active, and then when the blood sugars are lower, it can turn off. So it's actually a really kind of cool, sophisticated approach.
So they put it in these monkeys who they've made them diabetic.
They make them diabetic, give them this injection, and then it essentially can normalize their blood sugars.
What happens after the studies are over to the monkeys?
Oh, they have a good time, I guess. All right, so why are Ozempic and other similar drugs not prescribed for type 1s? Well, like I said, the main issue is that they're not covered. So people have to pay out of pocket. And we're hoping that would change when there's official studies in type 1 diabetes, an official indication, which means that insurance companies would have to, cover it. But again, they can be a loophole if you use them for weight loss, or sometimes if your provider puts insulin resistance or some other reason.
Well, mention some of the smaller studies that have been done in type 1.
Yeah, so in
some of the
general,
results.
For people that go on GLP-1 drugs like Ozempic and type 1s, their A1C comes down 0.3 to 0.5%. So it's helpful. It's not like a huge change, meaning you might go from 7.5 to 7 or 8.5 to 8, that kind of thing. People lose weight just like they do with type 2 diabetes and obesity. The amount of weight you lose depends on the dose and stuff like that.
Less variable?
Less variable blood sugars.
More time in range?
Using less insulin. You do have to be careful about low blood sugars because these drugs don't cause low blood sugars, but when you lose weight and you're eating less, you generally need less insulin. So you might have to back off how much insulin you're taking.
Yeah, and that's why wearing a CGM is helpful, and also working with your caregiver. So it's actually, and we don't really know if they have the same cardio-renal protection in type 1s. And a lot of people feel that they probably do based on the pathophysiology of diabetes and how these drugs work, but you don't know until you study.
Where can you buy the hypo pen? Well, there's lots of types of glucagon emergency pens, like the Gvoke pen that you mentioned. There's Baqsimi, which is a nasal spray into your nose. But the ones that we were talking about, the mini dose, like a couple units, that doesn't exist yet.
Well, hold on.
Tell them about it.
Okay. Well, Xeris, they make the Gvoke hypo pen, but you can have your doctor prescribe the vial and syringe. So the glucagon comes in a little, like a vial, like the old insulin vials, like the ones we used to fill up our pump, and a syringe. And you don't have to suck out the whole 1 milligram. So there are people out there, hats off to Gary Shiner, famous book, Think Like a Pancreas. And you can actually figure out how much you need for any particular situation, a blood sugar with a trend arrow. So you can actually do it right now. Ask your doctor, you don't want the hypopen, you want the vial and syringe.
Cool.
Yeah, you didn't even know about it.
Well, yeah, I did because we just talked about it. But I wanted to give you a chance to talk. That's how it works.
I get
Tit
it.
for tat.
I get it. Okay.
Do you recommend, it says Dexcom for people with type 2 diabetes. So yes, we recommend continuous glucose monitors in general for people with type 2 diabetes across the board. However, to get it covered by insurance, you generally have to be on insulin, any kind of insulin. So yes, we want continuous glucose monitors for all.
Yep.
It comes down to coverage.
Yeah, and I'd just say that there are people that buy it on their own. And if you're not on insulin, you may not need it 24/7. And for the your relatives, guilt them into buying some for you. You can go to Walmart, you can go to any place. You need a prescription. So, you can ask your doctor, as long as you're paying for it. Most doctors would never say no. And yeah, it's one of those things that could actually be life-changing for someone with type 2, literally.
All right. Any recommendations for long travel this holiday season with diabetes? So that's a great question.
Really good question.
Specific recommendations might depend on if you have type 1 or type 2. But no matter what you have, it comes down to packing everything that you need and in surplus. Because if something's going to go wrong, it's going to happen when you're traveling. You're going to drop your insulin on the floor, or medications expire or something. So you need to take things and kind of duplicate. I think in general, people get a little too worried about keeping things cold and stuff like that. Don't need everything on an ice pack. You can have things at room temperature for as long as you're traveling, and then put it in the fridge when you get there if you need to. Same thing with letters. Everybody asks me, can I get a letter for all my stuff?
You don't need that anymore.
You don't need it. So if you have one, great. But generally, just pack your stuff. Get everything you need for glucose monitoring, CGMs or your meter. Take all your medications, and you should be good.
I'll add that. Make sure you, and this is basically what you implied, have it on your carry-on suitcase. Don't ever leave your diabetes supplies unless it's extra in the check baggage. And another idea is to give another set to your companion who you're traveling with, your wife, your boyfriend, whatever. And Murphy's Law, what can go wrong will go wrong. Bring a glucose meter. If you're on a CGM, that thing could screw up. And you want to be able to at least prick your finger and see what your blood sugar is. And that's important too. So, yeah, just be prepared. Bring extra. Split them up into 2 different carry-ons.
Again, we did a great video on the website in the video vault. I think it was under type 1 maybe on travel, where Steve and I literally had our bags and talking about what we're packing and all that. So it was a fun one.
A third of my bag was
pretty much
damn diabetes supplies,
So we'll do some rapid fire one. Do you recommend low carb keto it says type 2, could be for type 1. So you can do low carb or keto even if you have type 1. The definitions for these are a little bit variable, but we say keto is usually less than 50 grams of carbs per day. Low carb is, there's not like a strict definition for that. It says that it worsens your kidney function. That's not really true. So you absolutely can do low carb.
Stop reading Reader's Digest, please. What is a low carb diet? It's basically a very low calorie diet, and no one can do it forever. But as you always mentioned, if your diabetes is messed up, the best way to get it under control quickly.
Yeah.
And
get back on track. So that's usually how I use it. And actually, you and I both eat low carb. I think certainly by American standards. But I'm more rigorous with it when I'm feeling out of control, and then more loosey goosey maybe around the holidays or things like that.
Holiday is not the best time to try
that. Is Mounjaro or Trulicity better for someone with chronic kidney disease? What would you say?
Well, Mounjaro has not been studied to prevent kidney disease. And drugs like SGLT2s are better. And Ozempic did a big study called the FLOW trial. And that showed reduction in the progression of diabetic kidney disease.
So specifically, it'd probably be Ozempic. But
Excuse me.
If you could only get one of these covered, Mounjaro, Trulicity, I wouldn't worry too much about it.
Yeah.
In a perfect world, I have great control. How often should I see my endo? That depends.
How much does he charge?
Yeah. If you have type 1, you should probably see your endo once a year.
Yeah.
If you have type 2 and you're just cruising, and you're just on oral drugs, you might not need to see an endocrinologist at all. You know, depending on how good your primary care is with diabetes, et cetera. So that kind of depends.
Yeah, you know, it's always good to check in with an endo because let's just say you have episodes of congestive heart failure and your diabetes under perfect control, but you're not on an SGLT2 inhibitor like Jardiance or Farxiga. You know, that's a good time to, you know, that you would learn that you should really be on one of these drugs.
Yeah.
So it's good to check in at least once in a while if you're a type 2 with good control.
And sometimes it's dictated, like Medicare sometimes
Yeah,
will mandate
yeah.
that you have to see somebody every 3 months, even if your control is great. So that can be really frustrating. So
You know, I
it
like to see
depends.
people face to face in clinic, but if you're just making an appointment because you have to be seen and have a note in the chart, then I don't mind a video visit because you're under good control. We'll go over your diabetes the first minute. We'll schmooze for a few more minutes. I'll charge the whole level 5.
So last couple quickly, side effects with Ozempic. Really, it's people can be nauseous, they can feel really full, they can have gastrointestinal issues. That's particularly when people start. So we have people start low and kind of titrate up slowly. If you can get over that hump in the first month or so, people tend to do really well.
Yeah.
And trust us, it's worth it trying to stick through any issues that you might have in the beginning and not just abandoning it, because you can always go back down to a lower dose and go up really slowly. So I find that the vast majority of people can tolerate these drugs. Yeah.
My tip, which I want to patent as an idea, is that I always start people on half the typical starting dose of Ozempic, which is 0.25. If you look at a pen, it might be 40 little clicks till you get to the 0.25. I have them do 20 clicks once a week for at least 2 to 3 weeks. If there's no nausea, then they go up to the 0.25. That really works because we know from drugs like Zoltify and Soliqua, the slower you titrate these drugs, the less nausea you have. And I agree with Jeremy, most patients have no problem with it. But you also cannot predict who's going to get nauseated, who's not. So I always start low and go slow.
Best hybrid closed loop pump system for 2024. Again, it depends. There's a lot of good options out there.
Oh my gosh.
Omnipod, if you don't want to wear tubing. There's the iLet now where you don't necessarily have to enter carbs. So just, there is no best one. The algorithms are actually comparable. It's more about lifestyle choices. So ask your provider, go onto our website, get information on all of them. And for all of these, there's usually like a 30-day kind of like trial period. So please take advantage of that. If you use one and you're like, I don't like it, change it out or send it back in because you don't want to get locked into, using this pump for a long time.
Yeah, I mean, it really depends on you. If you're someone who really doesn't like to count carbs, you get confused with the correction factor and basal rate and all the adjustments, the iLet might be good for you. You just say, I want a large, medium, or small meal. But if you're someone that really is meticulous, really on top of your diabetes, likes to make micro adjustments, then you might pick the Omnipod 5, the Tandem. The Tandem has that new Mobi pump, Medtronic 780G. So there's lots of choices.
All right, last question. High blood pressure numbers, information on that. You did a really good talk again on the website in the type 2 category.
Thank you.
Just said, know your numbers. So what should your blood pressure be? What should your cholesterol be? What should your weight be? What should your A1C be? And actually taking these to your provider and just saying, how am I doing with each of these? In general, we want to keep the blood pressure. What's your goal that you tell people?
Less than 130 over 85 for sure.
So, know what that number is. Getting a home blood pressure cuff, measuring, every once in a while, seeing where you're at is huge. So we covered a ton, but you want to say anything to close out?
I want to say one thing about the blood pressure issue. One thing this is another really good tip. Most institutions and doctors' offices have a thing called a 24-hour blood pressure monitoring device. And what that is they put the blood pressure thing on your arm and a little pump on your belt, and you wear it for 24 hours. It measures your blood pressure every hour during the day, every 20 minutes.
You just did this like 2 weeks ago, right?
Yeah.
Yeah.
No, sorry, every 30 minutes during the day, every hour at night. You sort of forget that it's on, but it pumps up. And man, you get an incredible readout of your daytime average, your nighttime average, your heart rate, and it gives tremendous information on what your real blood pressure is. You've been to the doctor's office. At home, it's normal. There, it's like sky high. And it gives you such a great idea. And if you're high during the day and at night, and it can tell your doctor when to prescribe medications at night, during the day. If the medications are working, do you need another one? Blood pressure is key for your heart, for your eyes, your kidneys.
Cool.
That's another good tip. 24-hour.
Well, he
blood
sent me
pressure
this
monitoring.
picture. He said, "Hey, check out this new pump I'm wearing." And it was a picture with this huge tube on it. I said, what's that garden hose coming out of there?
One vial of insulin 3 times a day. He didn't know what it was.
But so anyways, thank you for watching. The whole point here is we want you to have a happy, joyful holiday season. Some of the things that we talked about are available now, actually a lot of these things. And some of them are, a wish list, but not like we're making stuff up. This is, a wish list for what's coming, hopefully in the next, year or two. So things are, they're doing better now than they used to be, and they're getting better. So please take a moment, pat yourself on the back. You're living with this crappy disease. If you know somebody with diabetes, you love and support them, give them a pat on the back and say congratulations for all the hard work you're doing. So congratulations, Steve.
Yeah,
Happy
congratulations.
holidays. Thanks for watching, and we'll see you at the next one.
Have a great holiday season, everybody.